everyone, and thank you for joining us today. My name is Dr. Carol Warshaw. I'm the Director of the National Center on Domestic Violence, Trauma, and Mental Health, and I'm delighted to present today's webinar on supporting women in recovery, a trauma-informed approach to substance use treatment. Today's wonderful presenters, maybe we could do the next, oh great, next slide, are Gabriela Zapata-Ama and Dr. Andre Jones. Andre is a professor in the Department of Obstetrics and Gynecology at the School of Medicine at the University of North Carolina in Chapel Hill. She's also the executive director of UNC Horizons, a comprehensive drug treatment program for pregnant and parenting women and their drug-exposed children. She's also an adjunct professor in the Department of Psychology at UNC Chapel Hill and an adjunct professor in the Department in the Psychiatry and Behavioral Health Sciences and Department of OBGYN at the School of Medicine at Johns Hopkins University. Dr. Jones is an internationally recognized expert in the development and examination of both behavioral and pharmacologic treatments for pregnant women and their children. She's received continuous funding from the United States National Institutes of Health since 1994 and has published over 175 publications and plus 2 books on treating substance use disorders. She's a consultant for SAMHSA, for the UN, for the World Health Organization, and is involved in a number of international projects, but also just does wonderful work on these issues. Gabriela Zapata-Ama is our new and wonderful Director of Policy and Practice for Domestic Violence and Substance Use at the National Center, as well as adjunct faculty at the University of Chicago. Gabriela brings a decade of experience working with survivors of domestic violence and other trauma, providing direct services, training, advocacy, and consultation, and leading programs using a trauma-informed approach, motivational interviewing, harm reduction, gender-responsive care, housing first, and third-wave behavioral interventions. Gabriela has been recognized with numerous awards, including the Health and Medicine Policy Research Group's Health Award in 2018 and the Illinois Association of Addiction Professionals chapter of NADAAC's 2017 Rising Star Award. Gabriela has provided training and TA related to serving marginalized communities impacted by trauma and other social determinants of health locally, nationally, and internationally. So we have just a wonderful, 2 wonderful presenters for you this afternoon. Before we get started, I'd like to go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on the Using this Webinar System tab in the center of your screen. You can switch to the screen from the slides by clicking the down arrow next to Using this Webinar. Please be aware that your screen might look a little different depending on whether you're using a Mac or a PC. On the right-hand side of the screen, there are multiple boxes. Third from the bottom is the chat feature. You may have to click on the chat cloud icon at the bottom center of your screen to open your chat box. This feature will allow you to provide feedback and share resources with your colleagues, as well as get in contact with the trainers or myself if you have questions regarding the training content. You may contact Carla Alegria, also with the center, if you have questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You'll see a lot of options, but for this session, you'll want to select all participants if you'd like to respond to a question from the trainer or to contact center staff anytime during the session. You should click on Carla Alegria to privately contact her if you're in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on all participants, type in where you're calling from, and and then press enter. Perfect. Thank you all very much. Well, while you can get a lot out of the chat feature, there are times when it moves really quickly and can feel distracting. If this is true for you, feel free to minimize the chat box by clicking the arrow next to where it says chat. You can always open it again with the same arrow if you choose. We will be providing live captioning during this webinar. Below the chat box, there's a media viewer box. This will contain the options. If you do not want to see the captions, click on the down-facing arrow next to the word Media Viewer, the same way you might if you want to hide the chat box. Time permitting, I will be moderating the Q&A towards the end via the chat box. And at the very end of the webinar, you'll be taken to a brief survey. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to internet connection, so feel free to call back in if that's a problem for you. If you're experiencing technical difficulties and are unable to contact Carla, you may call WebEx tech support to resolve any issues. That phone number, which I'll post in the chat box, is 1-866-229-3239. And again, thank you for joining us today. So next slide, please. So this webinar is part of an ongoing series on opioids, trauma, and domestic violence that's co-hosted by the National Center on Domestic Violence, Trauma, and Mental Health, the Campaign for Trauma-Informed Policy and Practice, and more recently, the ACES Connection. Let's go back one. As many of you know, NCDVTMH is the U.S. Department of Health and Human Services Resource Center on Special Issue Research Center on Domestic Violence, Trauma, Mental Health, and Substance Use. And part of our work is to promote what we call an accessible, culturally responsive trauma-informed approach for the DV field, an accessible, culturally responsive DV and trauma-informed approach for mental health, substance use, behavioral health fields, as well as child welfare and legal fields. And we also provide an extensive array of resources, training and technical assistance, as well as research, policy development, and public awareness activities. The next slide, and this is a disclaimer that this doesn't represent the points of view of our funder. Next slide. And the Campaign for Trauma-Informed Policy and Practice is an all-volunteer national advocacy organization promoting federal and state policies based on both the science and practice of trauma-informed approaches. They take a lifespan, cross-sector public health approach, and you can learn more and find out more how to join their national advocacy network on their website. The ACES Connection, we don't have a slide for them yet, is a social network that supports communities to accelerate the global ACES science movement, to recognize the impact of adverse childhood experiences in shaping adult behavior and health, and to promote trauma-informed and resilience-building practices and policies in all communities and institutions. I'll now turn this over to Andre.
There's 500 of you all. This is so great to see the participants continue to click up. So we have a couple of objectives today. So first, to really talk about sex and gender differences that affect women's experience not only of substance use, but also of use disorders, their treatment and recovery, and what makes them unique. We're going to talk about some of the core elements of comprehensive gender-responsive care for women and their children. We'll look at increasing the application of trauma-informed care as one of those very key elements for gender-responsive care. Look at how to increase awareness of substance use coercion and the intersecting dynamics of intimate partner violence with substance use disorders. And then finally look at how we can overlay gender-responsive principles into the work that we do in treatment and recovery. Next slide. So I always think it's important when we talk about substance use disorders and women to take a historical perspective, because if we don't learn from our history, we're bound to repeat it. And so we know that gender-specific treatment really actually started in the 1700s. There was a Quaker organization that touted a over 75% success rate where they would treat just women together, and they would do things like gardening, give them rest, give them art projects, get them involved in a variety of different activities, as well as basic kind of psychotherapy at the time. And there was another asylum that was opened in 1864, and of those 4,000 applications, 400 of them were women. And that was really, again, another time when there was a recognition that women really needed specialized care. Unfortunately, there's been a long history of violence and stigmatization and discrimination against women, which has really pushed them to the margins. We know that it's often difficult to be a person who has a substance use disorder, but if you're a woman, it's almost a double stigma. And we've really often been placed into sort of male-dominated treatment system where the services and responses are really very masculinely driven or not women or more feminized driven. And so in the 1970s was when the first time there was National Institute of Drug Abuse funding focused on women, and they actually started with pregnant women who were using heroin and their neonates. And so here we are again, unfortunately, in our century and in our decade, really, again, struggling with how to best respond to women who have substance use disorders, particularly opiates, and their children's needs. Next slide. So we know that when we think about established sex and gender differences that individuals face in their lives who have substance use disorders, we know that often women, due to societal issues, face increased hardships. And you can see the bulleted list on that slide. So we know from very good data that when women come into treatment, they often are less likely to be employed than their male counterparts. They're much more dependent on some other person for their economic survival and stability. We know that the stress that they face due to poverty can lead to co-occurring mental health issues. For women in this country, the United States, we know that the rates of women who are being incarcerated are going up at an astronomical level, as well as the women that I work with at the Center for Horizons, which is also, I think, representative of other places around the country, over 90% of our women present to treatment with physical, sexual, and or emotional abuse, both in childhood as well as many of them have this ongoing into adulthood. And we know that the way that the nature of the drug use world works, often women have to place themselves at risk for a variety of negative health consequences, including HIV. And there were data from Rhode Island that showed that women were more likely to die of an overdose than their male counterparts. And the reason for this, when the folks looked into the data, was that our first responders had not been trained to look for women who might not have been using injection equipment or that might have been overdosing on pills or other things that they weren't trained to recognize. So luckily, there's been a turn with that, and there's been more education around that effort, but it's just a striking example of a gender difference. Next slide. And so we know that women and men often have differences in how they experience their substances. So, for example, we know that women and men can't drink the same amount of alcohol, and women that drink the same amount of males' alcohol will have greater, more negative physical consequences. And there's a whole host of literature to talk about the medical, psychiatric, and social consequences that women face, especially that are identified at treatment entry compared to men. So we recognize that women who have substance use disorders have different and more complex needs than men. We're more likely to have those psychiatric co-occurring issues, parental stress, because often women are the ones who are the main caretakers or sole caretakers of their children, and that creates unique stress. The trauma history we've already talked about. And then there are other specific barriers in terms of transportation, legal consequences for our women being involved in custody battles without economic resources, child protective services, where cases are more likely to be opened for them than there are for their male counterparts. So unique issues that need to be addressed. Next slide, please. So what does a substance use disorder look like in women? How is it unique from men? We know that how women initiate most of substance use, in a broad brush generalization, not for every single woman, is different than men. Women are more likely to report engaging in substance use, initiation of substance use, in some type of intimate relationship, often with a romantic partner, compared to males who often report initiation of substance use in a peer-type relationship. How women obtain drugs, it's very much a male-dominated world. So often, and I've had women tell me, their parents told them, oh, your body is your pocketbook, and the way you're going to get anything in this life is by using your body to obtain things, and that's often the way she works to obtain the substances that she's using. Where she uses those substances, women will go to extreme lengths often to hide their substance use from their children. I can't tell you how many women I say, oh, no, I was using, but only at night, only after I put the children to bed would I use substances. And how hard they would work to hide that substance from family and friends, and then how they recover. It's been, a male-dominated type of treatment facility often is under the philosophical approach if we have to break people down to build them back up, or if we take away things, that can be an effective way of getting people to stay in treatment and recover. Whereas for women, oftentimes when they come in, they've lost everything. There is nothing more that we can take away from them. And so what can we do to really start to build them back up, to get rid of the shame and the guilt and the stigma and the discrimination that they have experienced in life, and learn how to have connection with themselves and with others. Next slide. Gabriela, I'm going to turn it over.
And so, great. Thank you so much, Andre. And so especially looking at how that traditional treatment model doesn't work for women, especially women who often come with increased risks around trauma and intimate partner violence. And so looking at the connection between intimate partner violence and lifetime trauma and how they have significant effects on mental health and substance use, including adverse childhood experiences. And so looking at women accessing substance use treatment in the past year, there have been studies that have found that anywhere from 1/3 to 2/3 of women experience intimate partner violence in the past year. And in looking at a methadone clinic, up to 90% of women attending a methadone clinic had experienced intimate partner violence. We also know that trauma, including intimate partner violence and adverse childhood experiences, increases the risk for substance use disorder, and that substance use disorders in turn increase the risk for trauma. And so here we see potential for a vicious cycle forming for really anyone exposed to trauma and intimate partner violence, but especially women, given that these are there's such higher incidences for women. Reflecting on intersectionality, we see that lesbian and bisexual cisgender women experience higher rates of intimate partner violence than their heterosexual counterparts, and that transgender individuals, while the incidence is not well documented, and we need to do a much better job in general as a field documenting experiences of trans and gender nonconforming and non-binary persons, but the limited evidence that we do have points to over a 2 times higher rate when compared to cisgender counterparts. And then on the other hand, looking at LGBTQ experiences of substance use. So in SAMHSA's 2017 NESDA report, we see that the rates of substance use disorders were higher for individuals who identify as lesbian, gay, and bisexual. Unfortunately, we don't have gender identity data when it comes to this, but that's something that we hope in the future will be available. And so we want to really hear from you and find out that when looking at the intersection of intimate partner violence and substance use concerns, how has substance use coercion issues shown up in your programs? What are you seeing? Go ahead and type in the chat. That's right. So Laura Lopez shares that high rates of substance use coercion is just another means to control the partner. Victims of using substances due to their partner, seeing ongoing issues of power and control, and how substance use just becomes another one of those manifestations of the partner's attempt to exert power and control. Seeing a lot of trauma for both genders, absolutely. Pressure to use by controlling partner. threaten to have children removed. Absolutely. Making partner feel bad when she or he doesn't use. Yeah, and just that ongoing pattern of power and control. Thanks so much. So looking at some of the data on substance use coercion, we found that there was really a pretty frequent incidence of individuals who experienced any form of substance use coercion, then experiencing multiple forms of substance use coercion. Particularly striking is for those who do try to get help and access services around their substance use, that their partner then tried to prevent or discourage them from getting help. And then, of course, we also see there the partner or ex-partner threatening to report the alcohol or substance use in order to interfere with the things that they need. So here are some additional ways that substance use coercion can show up, and there are many, many ways that substance use coercion shows up. So this is just some selections. But, another piece is really sabotaging somebody's attempt to engage in medication-assisted treatment. For example, stealing their medication, making threats about their medication, using their medication instead of allowing them to use it, as well as exposing them to relapse cues. So cues that are associated with use and increasing those relapse triggers. Andre, I'm going to turn it back to you.
Thanks so much. That was great. So I think it's also important as we think about women that we're thinking about how they might have unique needs really from treatment entry to treatment engagement and recovery engagement, keeping treatment and recovery as distinct phases. So if I could have the next slide. So when we think about both entry and engagement, there are a number of overlapping issues that women might be facing. So thinking about the interpersonal and the intrapersonal. So as we talked about a little bit earlier, the psychiatric disorders in terms of things to be on the lookout for because they're in higher prevalence than their male counterparts, thinking about depression. I can tell you from the Horizons program, about 50% of our women come in with some kind of mood disorder. About 10% of them have eating disorders in terms of anorexia or bulimia or binge eating disorder. There's about a third of our women have anxiety disorders, and then of course post-traumatic stress disorders. So those can be, before women even get to us, can be inhibitors for getting to us and staying with us. We've already talked a lot about intimate partner violence, which women can be prevented from seeking treatment or prevented from staying in treatment in subtle ways by not providing transportation or giving them really negative messages about treatment, as well as more just the sheer preventing things like being locked in a room and not allowed to leave to be able to engage in treatment. There's the sociocultural issues in terms of the discrimination and the stigma that women face for having a substance use disorder. Their family, friends, significant others, children might not be supportive of them seeking treatment or engaging in treatment. And then there's the structural and larger systemic issues, which you, of course, can put discrimination and stigma in there too. But the sheer lack of availability of treatment, which we'll see a slide about that related to opioid use disorders, it costs money to be in treatment or to get back and forth from treatment. So the sheer economics of being able to participate with co-pays and things like that, not having access to child care of any type or child care that feels very unsafe. So women are left having to make the gut-wrenching decision sometimes on a daily basis of, am I going to treatment or am I going to care for my children? What's the best thing for my survival? And then obviously in many states now there's the criminalization specifically of pregnant women for using substances and the way that our social service system responds to substance use during pregnancy and parenting times. Next slide. So what can we do in terms of responding to women in a more gender-responsive way? Gabrielle, I think, is going to give some very great examples of this, but just in terms of thinking about talking with patients that have been successful and thinking about, what was it for you that allowed you to access, engage, and stay with us? What did we do right? Those kind of quality improvement, regular interactions, asking women what we're doing right, and then what the barriers are, because maybe their friends aren't there, or maybe we've had women that have dropped out, and if we can access them, really getting their input and understanding for what are those very specific individualized issues that have common cross-cutting themes. How can we build more safety for our women, just really thinking about the daily practices of how we greet women, how we interact in group, how we talk about women, do we use very pejorative terms and things like being manipulative versus trying to get her needs met. In terms of medication-assisted treatment, what are the hours of the treatment program? Do you have a child care waiting area? Do you have a play area for children if you can't have child care? What are those things that we can do? What are the pictures on the walls that are saying about how we're responding to gender, and not even necessarily, obviously not in a binary way, but how can we be welcoming for all individuals regardless of or encompassing their sexual orientation and gender identity. Thinking about recovery-oriented systems of care, which I'll mention a little bit later, can be more gender responsive, understanding unique needs of women, thinking about family-based care. What can we do when women can't come out, or who does she identify as family that we need to be engaging as part of her recovery or treatment? And then what are those other holistic practices that are important for her to have a successful outcome? Next slide. So just more about gender-responsive care. Gabrielle, is this yours?
Yeah, so thank you so much, Andre. I'll jump in. So a lot of these pieces we have covered so far, but if we really think about what are the core aspects of gender-responsive care for women, it is first and foremost engaging and responding to women's unique experiences. So understanding what some of those unique risk factors are, as well as protective factors, and just what's unique about their experience of initiation into substance use, experiences while in their substance use, and then experiences on their path of recovery. Using a trauma-informed approach, a relational orientation, so that the healing happens in the context of relationship, that services are holistic and comprehensive to respond to the needs of women and their family, and as Andre mentioned, that women are the ones that define their family, that really the person we're serving is the person who decides who is included in their family and who is not, and that's very much informed by culture. And that our services provide a healing environment, both physically as well as relationally and emotionally, and we'll get more into that.
So then moving to engagement and retention, and what are some of those strategies that can be really helpful for women? And first and foremost, developing relationships early. I think, being able to help women know that they can trust us. So what can we do to live up to our word to really engender trust? And making sure that there's a continuation or a consistency in those relationships throughout the time that she is in treatment or going into the more recovery-oriented systems of care. Who can be that point person with her? How do we work with waiting lists? What can we do in terms of interim services if we are bombarded with individuals who need substance use disorder services? One of the things that we do at Horizons is we use a peer support specialist. And while women are waiting for residential treatment, our peer support specialist is calling her and going out to her home to see how she's doing, what kind of survival services might be needed, how we can get her hooked up with dental care, physical health care, other types of care while she's waiting to come in. We can't talk enough about the use of motivational strategies and motivational interviewing, and particularly this lovely non-confrontational way of being with people and helping people feel heard. being really good about being more businesslike about what we're doing in terms of returning phone calls or sending reminder phone calls, sending text messages or emails to women to help remind them about their schedule, because oftentimes it's a very chaotic life that they're facing living, and having that connection can be really helpful. Providing continuous feedback, and especially when we notice things that women are doing well, to honor that and reward that. Notice that verbally. You know, hey, today I saw you did a really great job in group talking about such and such and such and such. Thinking about on a very regular basis what our environment looks like, and not just the physical environment, but the emotional environment. What are we tolerating in the words and actions of our staff and of our patients or clients that might be not safe for people, and having those conversations. Obviously, engaging women's partners when it is appropriate, and knowing when to not engage partners. So what is our screening process for determining someone's going to be safe in order to come into treatment with the woman and really partner with her? Addressing the co-occurring disorders, of course, and then really working to engage women in an individual way, finding out what's important to her, where we're giving her choice and voice and power. Next slide. So we want to develop those relationships early, and so just to expand a little bit more about that, that really starts from the very first phone call that a woman places to the program. Having a warm and welcoming voice can be such an important thing, and then remembering her name when she walks in. Being able to have continuity among the staff, which we've talked about, and then the structured support contacts with our agency, and then doing that kind of warm handoff. So once she trusts you, when she needs to go to a place of referral, making that bridging phone call so that she can start to establish that relationship with another person pretty early too. Next slide. Oh, Gabriella, that's yours.
Thanks so much, Andre. And so one thing we can look at is increasing access for women who experience intimate partner violence and trauma. And so something that we can do, especially for those of us that are working more in substance use or behavioral health settings, is to become really aware of intimate partner violence dynamics as well as trauma. And so really it calls upon us to engender an approach that is informed by trauma and intimate partner violence, and that through that awareness, we can build safety into services and interactions for women to be able to discuss intimate partner violence, safety needs, trauma, and substance use coercion. And that this knowledge can be really interwoven throughout all of our processes, from first contact to billing to assessment to integrated safety planning for intimate partner violence and substance use, as well as just ongoing treatment and recovery. Something that becomes especially important is the availability of treatment on demand and having an array of options and services. That a one-size-fits-all is not going to be effective, and that, you know, as Andre mentioned, if there isn't treatment capacity right then and there, then how can we engage individuals and how can we help them build safety, both related to their substance use and potential violence issues from the very first contact. In this way, part of the knowledge around trauma and intimate partner violence helps us understand that when someone is having trouble engaging in our treatment services, that isn't about someone's lack of willingness, that isn't about, it would be kind of a leap or an interpretation for us to describe a reason why they're not able to engage or come in. And so in that way, it really calls upon us to reflect on our system and figure out how can we make our system more accessible and more responsive to the immediate needs of someone, and really keeping an open mind about what might be going on for them that's making them hard, that's making it hard for them to engage in our system the way that our system is set up today. And so in this way, the services that we provide are based on need, not on notions of compliance. And so this makes us, this calls us to really take a hard look at procedures around involuntary discharge and what does it mean to not provide a service that someone very clearly needs. And a very important step on this journey is to partner with local domestic violence programs to really ensure those warm handoffs, those seamless transitions, and those continuum of services for survivors and their children. For more information, you can go to our center's website and check out our toolkit for coercion related to mental health and substance use, which is a practical guide for programs providing primary and behavioral health care. And so something that we want to really shift in our thinking is not so much how do we, how do we find out from people what's happened to them, but more so, how do we build safety into our relationships, into our environment, into our interactions, where survivors can feel like they can talk about their experiences, where they feel like they can share their experiences. What I found time and time again is that as soon as somebody has that sense of trust and safety, that we have been able to demonstrate our trustworthiness with someone, folks are just dying to tell us. They are just can't wait to kind of find someone who they can finally trust to be able to share some of these pieces that are very painful and very difficult. And so for us, that takes building safety from the very first contact. So from the first time that someone walks in through the door or calls us, being able to ask them in very general ways, you know, is this a confidential phone number? Would we be able to leave you a message? Do we need to, you know, what do we need to have in mind when we're leaving a message if we are able to leave a message? If you need to get off the phone, you know, to maintain your safety, just hang up and call back when it's safe again. And not necessarily prying into reasons why that might be from that very first contact, but showing that we value their safety and we really want to empower them and enhance their self-determination. And that takes striking a balance between neither prying into nor silencing trauma stories. So it's a very delicate art to be able to pace people in their trauma stories so that they don't necessarily feel overexposed, but at the same time, making it a containing and a welcoming space. And that takes time. We need to allow time for that relationship to develop, just like any other relationship. And so many times with that first assessment, I share with people, you know, I have a whole lot of questions today, and I also expect us to naturally get to know each other as time moves forward, that our relationship is going to organically unfold like every other relationship. And of course, within that is very clear information around confidentiality, transparency, and all of that is part of informed consent, that we need to engender and express a non-judgmental approach and unconditional positive regard, and that we need to hold that for ourselves as well as make that apparent to others, that it's not enough, you know, in my head that I am approaching something non-judgmentally, but that there's a whole range of nonverbal and verbal communication where someone can really feel that non-judgmental approach and that unconditional positive regard. That our approach is minimally invasive and that we prepare people before we ask some of those more invasive questions, always highlighting their choices and pausing to give options of, you know, how would you like to proceed at this point? You know, here, you know, I mentioned that I'm going to be asking you a lot of very sensitive questions throughout the course of this assessment. Here come some particularly sensitive questions. All I need is a yes/no pass, and I'm here to listen to as much as you would like to share in this moment. And that all of this really rests upon a culturally responsive and trans-affirming care. And so moving into trauma-informed approach, you heard some of those pieces in what I was just describing. But overall, the trauma-informed approach, it's a perspective that supports the resilience of people and communities, and it's a perspective that is engendered through the way that we do our work as well as the services that we provide. And so in integrating survivor experiences, this looks like active listening and eliciting of women's experiences, empathy, seeking to understand their subjective experiences as services and our interactions so that their experience becomes an outcome onto itself. And that we really understand their adaptation to unsafe experiences and environments and attempts at coping as strengths, and that we're building on those as strengths rather than pathologizing them. And so here there are so many levels of validation, and one that I'd like to highlight is that people always make sense within their context. And that's where the importance of empathy becomes so central. And that reducing traumatization. So why even talk about traumatization within our programs? Well, trauma, as well as intimate partner violence, occurs within a context of power imbalances. And that naturally there are power differentials within our provider and participant relationships. And so because we do exist within a power differential in our services, it becomes so important for us to really focus on the potential for trauma and re-traumatization within our services and to actively seek to reduce traumatization. And so this involves policies, practices, and interactions at every level of the organization, as well as within the greater community and system. And that we're really called upon to integrate that knowledge of trauma, potential responses and signs of trauma, as well as knowledge of power dynamics to develop environments, relationships, and interactions that are characterized by safety, empowerment, and collaboration. And that this isn't something that we can just do once and check off a list, that this requires ongoing processes for reflection, feedback, awareness, and growth on a personal and organizational level. And finally, access, that we do all of this in order to increase the access, engagement, and positive outcomes for individuals and families impacted by trauma, and that this becomes especially important because of the increased risk for trauma that women experience. And so taking a little deeper dive into that trauma-informed approach, we have considerations around our physical and sensory environment. So I like to think that our physical and sensory environment needs to be inviting. I learned once that there are these chairs that people make, and I imagine some people buy, that are designed to be uncomfortable so that people don't stay there and sitting in that chair for a long time. So I mention that because that is literally the opposite of what we want to do. We want our spaces to be inviting, inclusive, healing for women, for everyone who comes in through our doors, and for their children. We want to have an environment that is culturally responsive and linguistically accessible. And so I have here the picture of the safe zone. And I can tell you, I had this up on my office door. And so often there were clients that when I was working in a permanent supportive housing capacity, there were clients that had been served for 7+ years by the organization. But it wasn't until they saw this very, very explicit sign on my door that they came in and started disclosing and sharing themselves with me and feeling like I could be a trusted person and that our program could be a trusted place where they could be themselves. And so asking ourselves, do the people that we seek to serve are we somehow implicitly, unknowingly sending messages that they somehow can't be themselves in our services, that they have to pretend to be someone else in order to get their needs met? Or do people walk in through our doors, or do people come into our doors and feel that they are kind of respected and seen and reflected in our environment, and that they not only can be themselves, but that who they are is welcome and celebrated? And a relational environment, so especially for individuals who have experienced interpersonal forms of trauma, we can consider that the hurt happened in the relationship and that the healing happens in relationship. And so, all of these touch upon each other. So not only that caring and that respectful and that nurturing, but also that empowering and that transparent, and that emotional safety is really built on that trustworthiness, that transparency, and that mutuality. And then the overall programmatic environment. Is our program predictable and consistent? Or are people kind of feeling like they're walking on eggshells, not knowing what's around the corner? And then balancing that predictability with also maximizing choice, flexibility, and responsiveness to those individual and family needs. And so a trauma-informed approach involves us providing access to a range of healing modalities and practices, as well as creating community partnerships to ensure survivors and their children have access to trauma, mental health, and substance use services. Trauma-informed organizations support survivors to feel more connected and empowered, and help prepare them for situations that are potentially re-traumatizing, such as participating in a court hearing, a job interview, or custody evaluation. And lastly, a trauma-informed approach fosters an awareness of what we as service providers bring to our interactions, including our own experiences of trauma, as well as the ways that we are affected when we're truly open to the experiences of other people. And so for more on that, please check out our website. We have this guide available. It's an organizational reflection toolkit on becoming accessible, culturally responsive, and trauma-informed organizations. So Andre, I'll turn it back over to you.
Yeah, thanks so much. Great work. So just thinking in terms now about a specific period of some women's lives, which is the pregnant and parenting period. And we wanted you to be aware of a wonderful clinical resource that was published by SAMHSA in February of 2018. And this is the first guidance document that really talks about opioid use disorders, but with pregnancy and their children. So always before there's been a sort of a separation between women and children. And now this takes a more dyadic approach to guidance about how to work with this patient population. And so there are 5 total recommendations that came out of it. It's very user-friendly. It's got 16 different fact sheets that are downloadable, and they've got specific fact sheets for patients as well as providers. But the first 3 that I'm going to talk about and then turn it over back to Gabriella is that medically supervised withdrawal, also known as detoxification, is not recommended during pregnancy. And the reason it's not recommended is because of the risk for relapse. We know that it doesn't work very well for non-pregnant individuals, and we really have no reason to think that it would work somehow uniquely in pregnant individuals. And so by detoxifying without having a really strong support system and support group and other forms of social support and internal support, you're placing your pregnant patient at increased risk for relapse and for fatal overdose. So the second recommendation was that both methadone and buprenorphine are safe medications for managing opioid use disorder during pregnancy, and that extends into the pregnancy period. And then finally, the third recommendation is that transitioning from methadone to buprenorphine or from buprenorphine to methadone is not recommended. If you have a patient who's having a good clinical response from whatever either medication they're on, then you don't want to switch it on them, because that can create a period of vulnerability and destabilization, which isn't going to be optimal for the woman or her fetus or her child. Next slide. Gabriella.
Yeah, so here, this is just looking at the facilities offering all forms of FDA-approved medication-assisted treatment for opioids. And so you see that there's just a lot of work to be done. That even, myself here in Chicago, an urban area that has a lot of providers, there are still huge issues around access. And so, especially when we talk about more rural environments, access becomes a much, much larger issue.
So then turning to the postpartum recommendations that were provided by the SAMHSA guidance document, breastfeeding is absolutely recommended for women who are receiving buprenorphine or methadone and are otherwise stabilized. A lot of times there's a lot of misinformation that women receive because providers aren't aware of the recommendations or don't know what the appropriate research literature is to support this recommendation. Another piece of information was that neonatal abstinence syndrome, that withdrawal that babies have after they've been born, that it shouldn't be treated with diluted tincture of opium, and that has to do with the amount of alcohol that is in this type of substance. Then there's a recommendation for extended skin-to-skin contact with mom. We can't say enough about how mom really is the medicine to best respond to neonatal abstinence syndrome, and that can be really difficult for some moms depending on where they are in their treatment and recovery, but it's something that we at least need to start with for the vast majority of women to have that contact with their baby to feel like they get this chance to bond. And then finally, mothers and infants rooming in. It's really important. We've found that rooming in has been a long-standing practice. We have lots of data to show that it is associated with a reduced need for using medication to treat neonatal abstinence syndrome, and that there are shorter lengths of hospital stay for mom and baby. Next slide. Also, don't want to forget about the fourth trimester. This post-pregnancy phase is incredibly important, and we know that there was a really important article published by USA Today that showed that the high mortality rate in this country for women after pregnancy, and there's also data to show that women who are using opiates come into the hospital and deliver, they are 4 times more likely to die in the hospital than are their non-opiate using counterparts. So this is something we absolutely have to pay attention to. And what do we need to do to better help support our moms who are in this really fragile stage of life with a new infant? So we need to make sure that we continue that physician or midwife contact, that they are not isolating themselves, that they have different sorts of social support, that they're learning about parenting practices and they have parenting role models, that we're helping to support them so that they have child care support, and that we're also continuing with their recovery planning, making sure that they have overdose and relapse prevention and that they have access to reversal if they do have an overdose, and then just supporting their overall maternal health. Next slide. So what is a comprehensive care program for pregnant and parenting or post-pregnant women? And we really want to be able to provide both physical health, mental health, and social types of services to help support in a multidisciplinary team the whole health of the woman. So going from illness to health, and what does that look like? And having a continuation of care that's not just hospital-based, but really active community linkages too. Next slide. And we've known how to do this. In fact, the tip from 1992 really talked about how to do this. So model programs, they should have outreach services, access to laboratory workup. So we're looking at, does a woman have anemia? What types of substances might be in her system that give us an opportunity to have a conversation and change the clinical tools that we're using? Does she have access to obstetrical, gynecological care, sexual health empowerment, as well as family planning options? Social services for all of those types of survival needs that she has, and also recognizing the true importance of case management, that it's kind of the connective tissue that holds all of the services that she's receiving together. Next slide, please. Next slide. Oh, thank you. So I just wanted to highlight for a moment the Center for the Center for Horizons, where we have comprehensive care for women and their children, where we provide trauma-informed and trauma-specific care, as well in the context of substance use disorder treatment, having child care and transportation that is provided on-site to and from the program, having an opportunity to be able to apply for jobs, get a job, and figure out what it is that it takes to have job maintenance skills. Legal services. Our women face a myriad of legal problems, from myriad of felonies, child custody issues, other types of court battles with divorces and things like that. Being able to have true early childhood intervention and psychotherapy parenting programs, as well as the medical care with the OBGYN care, the psychiatry, and then residential continue to outpatient to continuing care, all in the context of being able to have access to medication-assisted treatment in terms of all forms, methadone, buprenorphine, and naltrexone. And I think one of the things that makes our program really unique is that unified philosophy of care. And one additional point that's not on the slide is that when women go while they're pregnant, we have them see a doula, and this is the doula there's a team of doulas, so they meet all of the doulas, and so when they go in for labor and delivery, they have somebody there that is there that knows them in case they have no other family or other support, and the doula program has been fantastic. Next slide, please. Oh, that's you, Gabriella.
Yeah, wow. What an amazing center, Andre. It's just so, every time I get to hear about your center, I'm just so amazed. So looking at, given women's unique needs and experiences around how, their unique experiences in being introduced to substances, their unique experiences throughout the course of a substance use disorder, as well as some of their recovery needs. I'd love to hear from everyone in the chat. What might be some women-centered recovery support needs? So if we think of recovery support services as all of the services that make it possible for someone to build a life of recovery, very often provided by peer support specialists and recovery coaches, what might be some women-centered recovery support needs? We'll give folks a couple moments to type their responses into the chat. Child care services, that's absolutely right, Richla. And Misty too, child care. Breastfeeding support, parenting support, home-based postpartum care. That's so true. I remember after having my child, I was like, how am I supposed to get out of the house with this infant and all of these things and all of and how I'm feeling? So having really that home-based engagement, transportation, immigration attorneys, education on healthy relationships, boundaries, respect. Women's halfway houses, yes, recovery housing is a hugely needed resource, especially for women and their children. Housing, employment services, transportation, accountability partners, help navigating health care, clothing, emotional support, legal advice, medical care and a safe haven, insurance. How to find support groups, especially postpartum. Health coverage is a foundation for all of these things, absolutely. And mental health care with counselors who have experience with DV. An infant care specialist available for home visiting. And women affirming support groups and peer support. Thanks so much, everyone. And so here are some relationally oriented recovery support pieces. So flexible treatment schedule, family and dependent care resources. And, there's certainly not enough resources around childcare, and that can be an enormous barrier for individuals with children in their care. And I've also seen that Many women care for many people in their family over the course of their lifespan. So that may also include other forms of family care, including elder care. Couple, family, and child therapy and other kinds of services, coordinating children's services with moms, parenting development and support. Parenting ain't easy. I myself have an almost 4-year-old, and about once a week I ask myself if I'm a good enough person to parent a toddler. So parenting support, especially given that so many women themselves had parents who were using substances, had substance use disorders, or have experiences of childhood abuse themselves, that they may not have had those positive parenting role models or that parent kind of the multi-generational parent support to fall back on. Feminine identified supports and role models. And this becomes especially important in co-ed settings. As we talked about, a lot of treatment settings can be very male-dominated in that way. And so having some feminine identified recovery coaches and, alumni groups, and then, of course, women-only recovery-oriented spaces. And so we've heard a couple times about kind of this role of the recovery coach, also known as a peer support counselor, peer counselor, or peer coach. And recovery coaching is a growing practice, and there's just amazing outcomes nationwide coming out with the role and importance of recovery coaches. There are some really innovative programs. One in particular I know is coming out of Georgia and the great work of Neil Campbell, where recovery coaches engage women and families at the hospital who have had a baby born who was exposed to substances. And so really providing that peer engagement and kind of navigation and support, and how inspiring that can be, and really is the helps to address so many stigma issues. And so some of the guiding principles of recovery-oriented systems of care, of which recovery coaching is a core component, really aligns well with gender-responsive treatment and care. So many pathways to recovery. It is not one size fits all. My recovery journey is not going to look the same as the next person's recovery journey. And that recovery journey needs to be self-directed and empowering. So really kind of throwing out this whole idea that people need to be broken down, or that, any kind of concept that would really just come across as shaming and alienating. That recovery is driven by personal recognition of the need for change. And so that really highlights the importance of eliciting and motivational interventions that really help individuals come to those insights themselves. That recovery is holistic, that it has many cultural dimensions, and that recovery exists within a continuum of health and wellness, so that it's part of our overall health and wellness. That recovery is intertwined and emerges from hope and gratitude, involves the process of healing and redefinition for self and family, and that recovery needs to address discrimination and help people transcend shame and stigma. So we often talk about, what do we do with shame? We find someone we trust and we share with them the thing that we are ashamed about. And that's how we can really move past and neutralize shame. Because otherwise, shame really keeps us isolated and keeps us in our youth. And that recovery is supported by peers and allies. That recovery is characterized by rejoining and rebuilding a life in the community. And that recovery is a reality. It can and does happen. And so, Andre, if you can tell us about recovery-oriented systems of care for families.
Yes, and I will be brief because I know that we're over time. So just wanted to talk about the importance of ensuring that we have layers of support. We do, I think, a lot of us do a really great job at providing good treatment services, but oftentimes we are not given the resources needed to create a recovery-oriented system of care, not just for mothers, children, families, and I know in the chat box animals was mentioned, which I think is such a really important point. So often women leave and they're not allowed to take their animals with them. So what can we do in terms of the clinical treatments that we provide, but then nest that in clinical supports while women are receiving treatment, and then once they're completed their treatment and they're into their recovery, how do we help keep women well? And what are those services that are needed? Peer support specialist services, social services, and then in terms of a larger community, I really think there needs to be public, private, industry, university partnerships so that we're really creating a web of recovery in every community where we are. And I'll just give a shout out to Michigan because I know they created a division in their state for a recovery-oriented system of care. So I think it'll be really cool to see how they're able to establish that. And right now, the National Institute of Drug Abuse had a call out for recovery-oriented systems of care, healing communities. So there'll be research data coming out about this in the next couple of years. So just an opportunity to think more broadly about what we're doing. Next slide.
So I just want to do a quick time check. Do we have about 25 more minutes? Great. Okay. So we're good on time.
Okay. Thank you.
Yeah, I'm glad because I see a lot of questions coming through, and I think that we're going to have a really great question and answer session. And so one thing to consider is the continuum of family substance use treatment services. And so looking at from kind of level 0, which is individually focused, no meaningful consideration of family, all the way to level 5. And so I'll give just really brief descriptions of each of those. So in level 1, the focus is still going to be the individual woman's treatment, but the treatment plan is going to include some family issues and there's going to be some family involvement. And here, the goal is really the improved outcomes for women. In level 2, there's going to be the ability to have children present, and so children accompany women to treatment, and the children can participate in childcare, but typically won't receive any therapeutic services, and only women have treatment plans. So here, the goal is still improved outcomes for women, but with some greater kind of accessibility. For level 3, now we start moving into women and children services, where children accompany women to treatment, and both women and children have care plans and receive appropriate services. And here the goal is really improved outcomes for women and their children, including better parenting, or I should say parenting support. Level 4, we move into family services. So services are provided for women, their children, as well as other family members. And here the goal is better outcomes for women, children, and then sometimes including some of those other family members. And then finally at level 5, kind of the highest level of integration and family-based treatment. The whole family has care plans and receives individual and family services as appropriate to their needs. And the goal is improved outcomes for women, children, and the family as a whole, and improved outcomes in family functioning. Now, something to keep in mind is that there are counterindications for family-based treatment. So while making treatment responsive and available for everyone is typically going to be better because we know that the family experiences a lot of needs as a woman experiences or an individual experiences a substance use concern, but that we wouldn't want to engage someone in a family-based treatment if there are high levels of anger or presence of violence within the family. That could actually kind of increase violence in the family. So it really calls upon us to have an awareness of those domestic violence issues and dynamics. And then kind of finally, holistic services. So holistic services are important for everyone in recovery, but especially for women due to the higher incidence of co-occurring health concerns, economic instability, and how women are often juggling multiple roles, kind of wearing multiple hats in their lives. And so these different areas can be attended to both within treatment as well as through community partnerships and linkage. And that when we're looking at physical health, it's important to also include reproductive health and sexual health there, and in advocacy, also including care coordination, system navigation, and intervening on behalf of women to ensure access to needed services, and as well as assertive community support. I mentioned having an almost 4-year-old, and I can tell you that Chicago Public Schools was such a beast for me to wrap my head around. And I was like, I'm a licensed clinical social worker. I have degrees in navigating complex systems, and it is like writing a master's thesis to try to figure out this school system. And so, many times it's important for us to support women in navigating all the different systems that they're called upon to navigate, both as part of their recovery as well as just part of the roles that they play within their families. Andre, what would you like to add?
Oh, thank you. I think you've done a fantastic job. I think that I can't say enough about the idea of giving people the ability to have self-determination and to have them to find their voice and practice their voice and use their voice. And that comes in small ways as well as large ways, just wherever we can infuse choice into it and giving women that option and helping them also with their children have choices to, help them practice good parenting skills and then learn the lessons about, kind of the choices that they make in a safe and positive way. Thanks.
And so we'd love to hear from you. What is one thing you can implement quickly within your organization, practice, or your provider community to better support women in their recovery? And go ahead and enter some ideas in the chat box, and we'll read them out loud. We know that you can't quite see each other's what the other people are writing, which is such a shame because you're all writing such amazing things. Education. Connecting to community resources. More unconditional positive regard. Make closer relationships with SU centers. Absolutely, Ellen. And, that fostering collaboration across our siloed providers, so important. Hosting resource fairs, further training. Invite them to Seeking Safety, the Advocacy Center and Child Care Centers. More treatment facilities. Sounds like that might take a little time, but I think it's a great goal. Increasing empathy, helping with case management. And case management goes such a long way in building trust. We utilize the ongoing support of our women who are alumni through alumni group and sponsorship and activities. I love that, Gina. That's so important. Integrative services, trauma-informed spaces in the court, and more of a welcoming office. Well, Erin, I hope that you keep us updated on how that goes. I'd love to hear more. Access to updated research. Well, thanks so much, everyone. Here is a link to stay connected and find out about some of our future offerings. We have a whole host of series that we are launching now that we're in a new year. And one webinar that we want to really highlight is actually happening tomorrow. And so we hope that you can join us and join ACES Connection and Campaign for Trauma-Informed Policy and Practice for a free webinar to learn how to drive public policy change without kind of crossing that lobbying line, because especially those of us working in nonprofit organizations or have requirements by other kinds of funders, we certainly don't want to cross that lobbying line, and yet we know how important advocacy and advocating in the public policy sphere is for the folks that we serve. And so now we'd love to open it up and kind of spend some time getting to your questions. So if you have any questions, if you could put them in the Q&A box, that would be great. I'm kind of combing through the chat here to see some of the ones I saw coming through the chat. Yeah, so any thoughts on working with child welfare involved individuals and how to kind of buffer the potential for trauma and re-traumatization there? Andre, what are your thoughts?
Yeah, so we have child family CPS meetings pretty regularly, and I think communication. It seems like our team does a lot of kind of bridging communication between here and interpreting. Here's what the parent is trying to say. Let me rephrase that if that's okay, kind of things. And then also helping Child Protective Services give very concrete, specific, goal-specific tasks, helping Child Protective Services understand sort of more about the context of what's happening in the woman's life that they might not be able to otherwise understand, or at least be able to sort of really reiterate in different words what she's trying to say. But I cannot say enough about communication, and that takes time, for which the vast majority of that doesn't get reimbursed at all. But I think that that's really important. And also in terms of communicating, so we have a lot of communication with CPS when things are going well. So we'll actually have the mom send regular updates. Hey, little Johnny just learned how to roll over today. I'm so excited. Or, you know, Susie Joe started school today and I'm really excited. So that CPS gets a flavor of, you know, both positive strengths as well as what else is the more concerning issues that are going on. And that's been really helpful for us. The other thing that we do is we actually give Child Protective Service updates, like in-services. We try and do that every quarter to every 6 months. And we had our local Child Protective Service pick topics that they were interested in. And so one of them was trauma-informed care. And so we could go in and give like a little short 15-minute presentation and then have a discussion about what that looks like. Because a lot of our Child Protective Service folks don't get addiction treatment training at all. So they don't really understand what addiction is, how it's treated, what recovery is, you know, those types of things. And so that's been really beneficial for us.
So, Andre, it's Carol. There were a couple of questions about MAT and pregnancy, sure. And I think that feeds into the questions about working with DHS workers in the courts around mom as medicine. So one was if a pregnant woman, I'll read a couple of them because I think you could address them together. If a pregnant woman has not started MAT or methadone, is there a preference of what to use? What works best for baby to support mom? How does methadone affect the baby? Where can we receive information literature on this recommendation, you know, for mom as the medicine, and are there resources that can be shared with Child Protective Services because they often, removal is often a big issue. And I had written into the chat that there are 23 states plus DC where substance use during pregnancy is considered child abuse, and there are 24 states where there are reporting requirements. So there's a whole constellation of issues around there that maybe you could address.
Sure. I don't think I'm going to remember all of them. So I'm going to start with if a mom has an opioid use disorder that meets DSM-5 criteria for being severe, and which medication should she start on. And that really should be an individualized discussion with her, understanding what resources are in her area, because a lot of times there's only one. There's only a methadone clinic, or there's only a buprenorphine provider, or there's only naltrexone that's provided. And so sometimes we have to be really, really practical about, well, what is it that she can get to actually receive. But when there is an opportunity to have more than one medication option, then it really needs to be a tailored discussion about has she ever used one of these medications in the past? What was that like for her? And then if she's really naive to opioid medication and doesn't seem to have a preference, buprenorphine is considered, because it's a partial mu opioid agonist, is often a good place to start. And that's because if buprenorphine doesn't work for her, then you can go to methadone. It's much more difficult to transfer from methadone to buprenorphine, but it's relatively seamless to transfer from buprenorphine to methadone. So it gives you an option later on if the first one didn't work. In terms of how does medication-assisted treatment, or methadone, I think was the specific one, affect the babies, like neonates and then later childhood development. There is a tremendous amount of scientific attention that right now is in proposal stage trying to answer that question. We have data from the 1970s when I mentioned in my talk that NIDA, when they first started funding women's treatment programs and services and research, they focused on pregnant women with opioid use disorders and their children. And so we have cohorts from the 70s, but a lot's changed since then. And so we have a variety of different literature out there that says different things. I think it's really important that we look very carefully at that literature, because some of it, quite honestly, is not very good, and it has a tremendous amount of bias and confounds in it. I will highlight one study for you, which is the study that we did, which was a randomized double-blind controlled study that had women that received either methadone or buprenorphine during pregnancy. And then we looked at the primary outcomes for mom as well as for baby. And we did find that the neonatal abstinence syndrome, if babies were prenatally exposed to buprenorphine, they stayed in the hospital a significantly shorter period of time than their methadone counterparts, and also required much less medication in the form of morphine to treat the neonatal abstinence syndrome. And then when we looked at babies up to 36 months under blinded conditions in a variety of physical, cognitive domains, Baileys, things like that, we really didn't find any differences, nor were they significantly different from the norms on those tests. So that's the, one randomized double-blind controlled trial that I can share with you. It's the only one I know that's out there. Most of the other data are retrospective data cohorts. So, but I think that's one study. So we have a lot to learn in the next 10 years about this topic. So I think what is important is that we want to make sure that all children, be it prenatally exposed or not, are getting the best services that are available for them as issues are, they're screened and assessed and then identified as having needs. And then in terms of the literature for the support of mom as medicine, I think that was the third thing that was asked about. So Eat, Sleep, and Console is in terms of rooming in terms of that, is mom as medicine, the skin-to-skin rooming in. Ron Abrams in Canada published a number of papers on this. We at Johns Hopkins, we looked at this. There's a whole variety of papers out there. I'm happy to put together some example references to support that. And I believe it is talked about in the SAMHSA guidance, so that's a perfect resource for really looking at those additional references, or a more complete reference than off the top of my head.
Great. I'm just looking at Gabrielle, I don't know if you're Well, I'll ask the question.
Hi. You know,
it says my question about trans inclusive.
I'd love.
Yeah.
Oh, Sorry, I just saw a question that I'd love to answer.
Okay.
As I was looking through the questions.
Yeah.
So the question is, what are ways that harm reduction programs can have more women-centered services offered? I manage a syringe exchange program, and it's very difficult to deeply engage with participants because the interaction is often brief, unlike a treatment program. Thank you so much for that question, and thank you so much for the work that you do. It's so important to be able to support individuals who are continuing to use and to have different interventions available and supports available at every stage in someone's in the continuum of use and non-use. And so it's a question I'd like to give a lot more thought to, but some things off the top of my head is having some feminine identified workers, engagement workers, outreach workers, of course, people with lived experience who are also feminine identified who can provide that women-centered support, and having, of course, diverse folks kind of available at different needle exchange times and locations if you have multiple locations. And then something else that comes to mind is connecting people to women-led and women-centered drug user unions. So the Urban Survivors Union is women-led, and then there's also the International Network of Women Who Use Drugs, and also helping to cultivate the leadership and helping people who use drugs organize. And so if you don't already have a drug user union, perhaps helping to organize one and helping women who use drugs to have a central voice in that.
There was a question about, does anyone have experience transitioning a women-centered provider of space into one that also welcomes transgender women?
Yeah, so that I would say is pretty easy once the people involved have seen the need for it. And so it's not so much the how you do it, it's more so the why it needs to happen. And so I've seen a lot of providers make that transition once there were key change agents within the organization that it just really kind of clicked for them how important it was to expand to be inclusive of all women. And so from there, I would say that, you know, people change because of passion or because of pain. And so identifying who are the change agents within organizations and how are they someone that is more of a human story, more responsive to human stories? And do we need to get some kind of testimonials going? Or are there people that are going to be more responsive to data? And they're going to be more responsive to looking at the disproportionate impact and adverse health outcomes for trans women. And that's going to generate more movement within the organization. And so I would say knowing your audience and really tailoring the message to the audience and finding who are going to be your allies on the inside of that system or that organization. And then once kind of you have the hearts and minds, the how you do it, I've seen organizations figure that out really quickly.
Thanks, Gabriella. So are there more questions before we close? Well, we've just about run out of time. I want to thank you, Gabriella and Andre, for today's webinar, and thank you to Carla for making the webinar run so smoothly. And last but not least, thank you all for spending your time with the center. Within the next week, we will send you all a follow-up email with a link to the recording of today's webinar, in addition to the slides and handouts referenced, all of which will be available on our website. You'll also receive a certificate of attendance for your time today. At the end of the webinar, you'll be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, it would be greatly appreciated. And thanks again, and we hope you all have a wonderful afternoon. If you have other questions, please don't hesitate to reach out to us, and anything that we weren't able to respond to or materials that you requested, we'll try to include with the follow-up email and access to the PowerPoint.